Thank you, Sarah. That was a great presentation and certainly another view of how we really need to culturally tailor our navigation programs for diverse populations. Our final speaker is Stacy Fischer. Stacy is a physician with specialization in palliative care and gero-oncology at the University of Colorado. And she also has been looking at culturally concordant navigation programs. And her talk today is Navigating Palliative Care in the Health System and the Community. Stacy?
Thank you for having me here today. It's an honor to be speaking, and it's an honor to be part of this panel. And I'm humbled by the huge scope of work and integration and implementation that we've seen today. I'm going to present some work that's a little bit more of a deeper dive into a smaller project. And of course, have to acknowledge the funding sources that made this kind of science possible. We've heard a lot today about screening and prevention and treatment, and these things are so important. And yet, there will come a time for all of us where we face the end of our life. And the palliative care and the compassionate care with dignity is as important at the end of their life as it is through our lives. And when I talk to audiences and I ask people to imagine what they'd want their last days to look like, not surprisingly, people overwhelmingly picture something on this side of the screen, on the, I guess, your left. The reality is, for many of us, that our end of life will look far more what it is on the right, where it's really difficult to see if there's even a patient underneath all that equipment. And to be honest, I don't know if there is a patient beneath all that equipment. That what we want and what boils down to at the end of our lives is being in a space of peace with those we love, being treated with dignity, and more than anything, having what is important to us match the care that's given. And so when we think of palliative care and definitions, and for our audience today, I just want to make sure we're all on the same page of how I'm thinking about this. It's a kind of care that provides relief from pain and other symptoms. It's very common with cancer, that it's focused on quality of life, and is appropriate for patients with serious advanced illnesses, and that we treat not only our patients, but also their families. However, palliative care, like the rest of medical care in general, we have disparities in outcomes, and also differences, cultural differences that are very important to acknowledge as well. And so in thinking about that, and thinking about how to address these disparities, I spent many years looking at both quantitatively and qualitatively, what are the barriers that would need to be addressed in an intervention that tried to address some of the disparities that we see. This was based on a study that was done by Sean Morrison and colleagues in New York City. They basically did something incredibly simple and brilliant. They called all the pharmacies across all the 5 boroughs and in Manhattan and just asked them, tell me about the opioids that you stock. And then they basically figured out that which pharmacies carried adequate stocks of opioids to treat serious cancer-related pains and which ones didn't. And what they found, and this is part of the healthcare systems that we're talking about, is that pharmacies that were located in diverse neighborhoods that were overwhelmingly predominantly not white, were less likely to have adequate opioid stocks. Pharmacies that were located in neighborhoods that were predominantly white carried adequate opioid stocks. That's a problem right out of the barrier. So as we thought about thinking about systems, that was something we wanted to think about. What could address that kind of healthcare system problem? Then we also have patient barriers. This is something we hear all the time, and not just from underserved populations, but across the board. I don't want to get addicted to pain medications. Knowing that there's an educational component that needed to be incorporated into any kind of successful intervention to address some of these ideas, and to understand that there are other values that are competing with that. that when people have their pain treated, that then they can do things like take care of their family, be with their family, core values that are maybe in direct competition. We also found from some of our focus groups within the Latino community in Colorado, something we call fatalismo. Whatever's going to happen is going to happen. And actually, if I fill out some paperwork, it might even kind of make it happen sooner. And I'd be nervous to do that. We found that overwhelmingly to be an important point. So when we talk to our patients about this, to try to address it, to understand, in Colorado is something that's it's a very unique state in some ways because we're an interested party state. So what that means is when someone has a medical decision that needs to be made, it's not their spouse, it's not their child, it's not their parent. We gather all the people together and say, who do you group of people think should be the decision maker? So sometimes we have spouses, sometimes we have ex-spouses, sometimes we have adult children from first marriages. It can get very complicated very quickly. And so to understand that completing an advance directive that names your decision maker is something that can really help families, especially at the end of life. And then there's the idea of respect and personalismo. Patients wanting to be respectful of their providers, that there's a power differential. I don't want to bother the doctor. When they say yes, or how are you feeling? How is your pain? I just want to say it's fine. Don't worry about it. And this can be a huge barrier to getting adequate pain control. So when we think about how navigators can be helpful in an intervention, navigators can do things like activate patients and advocate patients, role play, use tools that are used in helping patients get to cancer screening, like motivational interviewing. That's a tool that can also be used to help patients be activated to seek control for their pain and to get better pain control medication. Another thing we learned in some of our focus groups is that hospice, that word, does not always translate well. And so with our Spanish-speaking focus groups, we talked about, it's sort of the Spanglish word, hospicio, that didn't mean anything to them. And when we asked for direct translations from patients, we got words like orphanage, insane asylum, nursing home where I can drop off my loved one at the end of their life. And so instead of a concept, a philosophy that's highly culturally concordant, care that takes place in the home with family providing most of the care, patients and families were imagining something completely different. And so incorporating years of quantitative, qualitative focus group work, we developed an intervention called Apoyo Karenia, which roughly translates to support with caring, which was a patient navigation intervention specifically designed to improve palliative care. We have a great research team. We received funding. Oops, sorry. Oh, wait, sorry. Okay, we received funding from the American Cancer Society to test our intervention. And so this was a culturally tailored patient navigator intervention. We were specifically looking at 3 main outcomes: advanced care planning, pain and pain management, and hospice utilization. Now, this was my sort of 5 or 6 years ago, and our thinking does evolve and science does improve. And so recently I was at a discussion with a number of other palliative care researchers, many of whom were very interested in disparities. And one of them said, sometimes we think this is what is involved in a quality death, right? To have your pain controlled, to use hospice, to not be in the hospital. But that's not always right. We think of that as a quality death, but that's not necessarily culturally concordant for everyone. That's not the right answer for everybody. And so one of the things that we wanted to make sure is that or at least our processes correct. At least we have informed patients making informed decisions. So decisions that are right for them, that's a great decision. And again, even though we showed those two pictures, right, of death at home versus death in the hospital, for some patients, death in the hospital is what is preferred. And then, so again, it's that goal concordant care. So as I present these data, I'm going to kind of put a focus not only on our outcomes, but also on the processes. And so we conducted this study over a 4-year period across the state of Colorado. And in some ways, I felt like with my colleagues, sort of a Thelma and Louise, we would drive down all over the state to these sites down in the far, far south. We've got Alamosa, Pueblo, out on the western slope, there's Grand Junction, Eagle Valley hospitals, and then our Denver hospitals. And so we would, to engage with these community partners took a lot of time and effort and was so well worth it. But I think as anyone thinking about research or thinking about community participatory action research, it's a huge part, and it's something that you need to budget a lot of time for. We enrolled 223 Latino adults who all had advanced cancer, either stage 3 or stage 4, into our trial. So all of our patients and all of our sites received some educational enrichment. All patients received culturally tailored, linguistically appropriate, so if they spoke Spanish, they got Spanish. If they spoke English, they got English materials that focused on our different palliative care domains of interest. All of these materials were grounded in the core Latino values that we identified through our qualitative work. And we had a community advisory panel that helped us develop our intervention and testing. So these are some examples of some of the written materials. And I think it's really grounding to hear some of the many similar themes that I've heard throughout the day. We tested our materials at a 5th grade reading level. As you can see, there were a lot of pictures involved. So even when our patient population had low health literacy and low literacy, that they could be engaged with this. Our pain brochure we developed ourselves on the far right, using both principles of surface cultural tailoring, making sure that the pictures in our pamphlet looked like the people we were working with, but also deeper cultural tailoring. And as you can see, when pain is treated, you can take care of your family, spend time with your family. So integrating some of the cultural values that we had learned about. So everyone received these, and patients that were randomized to their intervention group received 5 home visits from our patient navigators. And they basically had scripted guides each visit that were addressing our 3 core domains. In addition to that, our patient navigators were also doing many of the other things that we've heard described throughout the day, helping patients get connected to community resources, providing support to patients and their families. Sometimes that was bereavement support. Sometimes that was very simple logistical support. During the time of our study, there was a flooding up in northern Colorado, and some of our navigators were helping people that had now suddenly become homeless. And these are some of our wonderful, wonderful navigators, Rose, Claudia, and Diane. And this slide, I honestly could speak the entire 20 minutes about this slide. It's something of our work that I'm very proud of. When we think about some of the NIH priorities, engaging underserved communities and minorities into clinical cancer trials, into clinical trials in general, we know that we are not meeting these expectations. We are not meeting the standards that we have set out. And so the work of our navigators was incredible. I take no credit for any of this. This was really all of our navigators' work, that they were willing to engage with patients and their families on the weekends, at nights, in their homes. And all those aspects are so important in taking away power differentials, meeting patients where they're at, being flexible, understanding that people are trying to hold down a job, don't have enough money to pay for rent or to buy food, and so that the navigators were helping decrease that burden and not adding to it. we had 284 patients that were, and this is also as an aside, when we asked our community partners about how many patients they anticipated being eligible for our patients, the number we were starting with was actually 960. So as you can see, we had overly optimistic, well, and it's a good thing that there were fewer patients with advanced cancer to be referred to, but we were really, we had a lot fewer. So the fact that we were able to still accrue 223 was astounding. That's a 78% enrollment rate, which in any kind of randomized controlled trial is very, very high. Being that it's palliative care, it's even higher, and that we were working with this underserved population is something that is something to be very proud of for our navigators. And as you can see, we had very few lost to follow-up through the study period. Our patient population was a little bit older, 58, and for Colorado, the Latino population in general is fairly young. About half were women, about half were Spanish speaking, and as you can see, a very close to the, at or below the poverty line, and nearly half had less than a high school education. So thinking again about these process versus outcome, one of the important, even more important than any kind of paper document in a chart saying what patients want or who their decision maker is have they had the conversations that are important at the end of life? And so we asked patients in both groups, had you spoken to your family about your future healthcare preferences? And as you can see, I'm going to try to press the correct green button. 55% in our control versus 84% in our intervention had talked to their family. 35% had spoken to a healthcare provider in the control versus 60% in our intervention. And then when we looked at the paper chart or paper or electronic charts, many of these rural hospitals, it actually was paper. 33% had a documented advance directive in the chart versus a 69% in our intervention group. And we were really trying to, we approached our chart reviews in a blinded fashion, and we were almost always immediately unblinded because we would see our study form, which everyone received, but we knew at that moment that they were probably an intervention patient. When we look at pain management, we asked patients again about this process. Do you feel comfortable talking to your provider? And what we found is in both groups, it was astoundingly high. And when we looked at actual pain, and people are probably familiar with that 10-point scale, 0 is no pain, 10 is the worst pain imaginable. We had very low rates of pain in both groups. We think of 4 as a threshold. 4 and below is mild pain. So patients overall in both groups had very mild pain throughout. And when we look at quality of life, overall patients had very high quality of life. Where we see the navigators having an important impact is on symptoms. These are statistically and clinically significant differences here in the symptoms. That talks about nausea, constipation, fatigue, depression. And then finally, looking at hospice and end-of-life utilization. So one of the process questions that we asked patients was, would you recommend hospice for a loved one in the future? And then would you use hospice yourselves in the future? And what we found were there were pretty significant differences between our two groups. 65% of control patients said that they would recommend hospice for a loved one versus 88% in our intervention group. And 66, again, versus 88% for using hospice themselves. Over the course of the study, we had 120 patients die, and we looked at actual hospice utilization. And as you can see, the numbers are very high. These are not statistically significant differences and probably not clinically significant either. What's really crazy is that those numbers are about double the national average. So when we look at hospice utilization in general in the Latino community, it's about 40% of deaths will have hospice utilization. So it does leave me wondering if the randomized controlled design was not the correct design for this trial, because I think we may have had significant contamination. And that's a wonderful thing, because I think about it as the clinics changed, it improved care for everyone potentially. And so, conclusion, and I think I'm almost right on time here, we found that the patient navigator intervention was highly effective for advanced care planning and overall symptom control, and that we found that overall pain control and hospice utilization was at an excellent care rating in both groups. And a humble thanks to my wonderful, wonderful study team.